For the movement disorders, we're going to start off first with the hypokinetic disorders, and that really means Parkinson's disease. And then we'll transition into the hyperkinetic disorders. And because there's just so much to know about Parkinson's, most of this lecture is going to be on Parkinson's. Now, Parkinson's disease is a product of a loss of the dopaminergic neurons in the substantia nigra. Lots of words, but it's important to grasp that at the beginning. What happens is you lose the gas. You lose the ability to step on the accelerator to get the person moving. And so somewhere in the substantia nigra, it looks like this. You've got these neurons which tell the body to move. And these are dopamine-releasing neurons. Dopamine is released, binds to dopamine receptors, the D2 receptors, which then inhibit GABA. And GABA are inhibitory neurons that inhibit movement. The default is no movement. Dopaminergic neurons, when you step on the accelerator, disinhibits movement. If there's a gas, there's probably some brakes. And that is acetylcholine. Acetylcholine receptors stimulate GABA, thereby inhibiting movement. That's the fundamental problem with Parkinson's disease, is that you lose the dopaminergic neurons. Let's build a system in which dopamine exists. This is the blood-brain barrier. This is the way our medications are going to get into the brain. So ideally, we're going to talk about medication here is to build the system. You're going to ingest a compound that could get us more dopamine or more dopaminergic neurons. And as you see the system build, this will make intuitive sense when we talk about treatment. So this compound is called levodopa. And in the periphery, two things can happen to levodopa. It can break down to dopamine, which cannot cross the blood-brain barrier and so is useless to the brain. It can also break down into some other compound whose name you do not have to remember. But it happens by an enzyme called COMT. The third thing that could happen, and it's not in the periphery, is that levodopa could cross the blood-brain barrier where we want it. And here, the conversion to dopamine is really good. Right, this is, after all, what we wanted. Because that dopamine we put in the brain can then stimulate those dopamine receptors. Because remember, in Parkinson's disease, you lose the gas. The receptors are fine, you just don't have enough dopamine to make this gas pedal go. But in the brain, dopamine can break down, and it can break down into things that you don't have to know the name of. But these processes happen by COMT and by MAOB. So beginning to see where some of the therapeutic interventions can come in. Now this is the system, not the treatment. The idea being that dopamine in the brain, in the substantia nigra, stimulates movement. The problem, though, is that dopamine in the brain doesn't differentiate substantia nigra from anywhere else. If you get into the wrong tract and add a bunch of dopamine there, you actually get psychosis. In psychiatry, you'll learn that we use antipsychotics, which block dopamine receptors, a particular subtype, to prevent hallucinations and schizophrenia or delusions. We're going to give these people extra dopamine. We want it to go to the substantia nigra, but you can see how that might be problematic if the dopamine went somewhere else. And this is just crossing the blood-brain barrier. We can't actually control where it goes. So this is sort of the pathology. and I'll just write it out for you too, the pathology of Parkinson's disease is the loss of dopaminergic neurons in the substantia nigra. The patient is going to present with a hypokinetic disorder. And there are 4 things that really classify Parkinson's disease. The first is bradykinesia. Mask-like facies, trouble getting started. Cogwheel rigidity. They aren't fluid. They literally can't get going when you test their strength. The resting tremor, usually in the form of pill rolling. And the resting tremor is why it's talked about in comparison to the other hyperkinetic disorders. Even though this is a bradykinesia disorder, you're going to have a resting tremor. And lastly is gait or postural instability, which you'll see as the shuffling steps and they fall over whenever they walk. Now you can have other stuff. Right? You could have dementia, Lewy body dementia. You could have autonomic dysregulation, the Shy-Drager syndrome. But those are really low yield points. What I want you to learn are these 4 things are going to say, okay, you've got Parkinson's disease. The diagnosis is absolutely clinical. You could get a CT scan, but that's not going to show you anything. And you could get an MRI, and the MRI will show you degeneration of substantia nigra. But you only use brain imaging when you're not sure of the diagnosis. And if you're not sure of the diagnosis, it's probably not severe enough to do anything about. Bottom line is don't use any imaging. You make the diagnosis clinically. And the treatment gets a little bit complicated. Okay, where can we intervene? There's a couple of places. First, we could intervene at the level of acetylcholine, right? Just undo the brakes. So acetylcholine antagonists, like benztropine. This will theoretically work. Benztropine should only be used in young people with mild disease who basically have a tremor. The acetylcholine side effects really aren't worth it for the old people, and you don't really get at the pathology of the disease. So that's out. And I'll also throw it out there, because it used to be part of the treatment algorithm, amantadine. Yes, I'm standing in front of the word on purpose. If you see the word amantadine, it is wrong. Take that out of your Parkinson's vocabulary. Well, we already pointed out some of these enzymes, like the COMT inhibitors. These are going to be the capones, COMT inhibitors, and the MAOB inhibitors, like selegiline. But wouldn't it be cool if we could give someone dopamine exactly where they needed it? And that is what L-DOPA is. Levodopa is the name of the medication, often given together with carbidopa. And carbidopa inhibits the breakdown of dopamine. But good news, carbidopa, just like dopamine, cannot cross the blood-brain barrier. So the conversion to dopamine doesn't happen in the periphery, no side effects, and does happen more often in the central nervous system where we want it. So levodopa, carbidopa is the right answer. That's how you want to treat somebody. That's how you want to treat somebody if. Because you could also just give someone some dopamine agonists, not the actual dopamine itself, and activate the D2 receptors. Dopamine agonists are going to be ropinirole and pramipexole. Bromocriptine used to be in here. It isn't wrong. Its side effect profile just isn't worth it when you have ropinirole and pramipexole. All right, well that didn't help because there's a whole bunch of options. Which one do I choose, right? Okay, someone comes in with the signs and symptoms of Parkinson's. The only thing you need to do is ask, are they old and are they functional? If they are less than 70 and are functional, the right answer is to start off with dopamine agonists. Ropinirole or pramipexole. If they are over the age of 70, or they are dysfunctional, that is, they're not functional, the right answer is to start off with levodopa-carbidopa. That makes it a lot easier. You just pick one or the other. So what's up with the rest of the other ones? Like, what do they come into play? Well, realistically, the people who go on levodopa-carbidopa are going to have a wearing off of the effect. As more neurons degenerate, this is going to work less well. The more you use this, the less well it works. And this is where you're going to bring in the COMT inhibitors and the MAOB inhibitors to augment the function of levodopa-carbidopa, knowing that these patients are eventually going to deteriorate and die from their disease in the long term. So you want to give them as long as possible with functionality. And if medications fail, way back in your mind, pun intended, is going to be the deep brain stimulation. All right, Parkinson's is a big one. It's most of the lecture. We're going to move on to the hyperkinetic disorders, but before we do, let's review very quickly. Loss of dopamine, substantia nigra. Bradykinesia, cogwheel rigidity, resting tremor, and gator postural instability. Mask-like facies, pill-rolling tremor, shuffling steps. Clinical diagnosis, you choose between levodopa-carbidopa, if they're old or dysfunctional, and ropinirole, pramipexole equal each other, greater than bromocriptine if they're young and functional. The rest of this is to help you understand the system, because you might come across more complicated questions from Parkinson's. All right, that was Parkinson's disease, the only Brady disorder you need to know. Now let's talk about some of the hyperkinetic disorders you might run into. Starting off first with essential tremor. Essential tremor is familial. And what it is there a tremor that occurs with movement or with use. And it doesn't matter how close to the target you get or how much movement you do, it just comes up whenever you want to do something. So there's no tremor at rest. But when the guy picks up the remote control, he has trouble hitting the buttons. Or when he goes to hammer a nail, he might miss. I'm saying he because it usually is a man, and it is usually in middle age, 40 to 60. And it is often familial. Now this may be debilitating, but most of the time it doesn't really matter, it's just a little tremor. The diagnosis is going to be made clinically, and the treatment, if it's bad enough, will be a low-dose beta blocker, non-selective, like propranolol. Compare that to an intention tremor, which is caused by cerebellar dysfunction, either a stroke or alcohol. It sounds very similar, but looks very different. There is no tremor at rest, and then there is a tremor with movement. But it's very specific because it worsens the closer to the target you get. What you'll see is somebody try to do the finger nose to finger test. And I can do this no problem. What happens with someone with an intention tremor is that they'll begin to develop a tremor and the amplitude will increase the closer to the target they get. Whereas an essential tremor, they just have the same tremor the whole way. It's the worsening in amplitude getting closer to the target that separates out essential tremor from intention tremor. This also is diagnosed clinically. Of course, if it's part of a larger syndrome like a stroke, you might diagnose the stroke on MRI. But the MRI is not necessary to make the diagnosis of the intention tremor, and because it is caused by cerebellar destruction, there's no treatment. And while there are more tremor disorders than this, we'll talk about some of those that occur in psychiatry in the psych lectures. I want to finish with chorea, or choreiform using Huntington's as the model. And the reason why I do that is because it has so many questions that can get asked, and it becomes a board favorite. One, because it's the most common choreiform movement disorder, but also because of those genetics you learned about for step 1. Huntington's demonstrates anticipation. And the buzzword was trinucleotide repeats. It's autosomal dominant, and from generation to generation to generation, more of these trinucleotide repeats occur, meaning that the disease sets in younger and younger. The patient is going to have chorea, which is purposeless, ballistic and uncontrolled movements. This is chorea. Huntington's itself may have other elements to the disease, such as psychosis, depression, and they generally die by killing themselves. But what you're looking for is the chorea, and if you see that ballistic movement, that purposeless movement, then you want to think about anticipation. The diagnosis here, of course, is going to be clinical, and there is no treatment for this. First half Parkinson's, lots to know. Back half, the major tremors you need to identify, not that hard. Essential tremor is going to be a dude in his 40s to 60s who has a little tremor when he tries to use his hands, treated with propranolol. If this were caused by caffeine or cocaine, just stop doing caffeine and cocaine. Intention tremor, cerebellar dysfunction, worsens with amplitude the closer to the target it gets. Sorry, that's a stroke, can't do anything about it. And Huntington's, remember the trinucleotide repeat in anticipation, recognizing chorea as the major symptom of Huntington's. That's the movement disorders.